Bonjour à tous. Merci d'être revenus après ce bon repas. Et je suis très heureuse d'introduire le professeur Chris Sweeney du Dana-Farber Institute, qui nous fait l'insigne honneur de venir présenter aujourd'hui les récentes données sur le cancer de la prostate métastatique hormonosensible. Je vous rappelle que Chris Sweeney est le leader de l'étude Charted qui avait démontré un bénéfice de survie concernant l'association taxotere-castration versus castration seule. Et donc, ça a révolutionné la prise en charge du cancer de la prostate métastatique sensible à la castration. Et récemment, il a présenté à l'ASCO 2019 l'étude en Zamet. Et donc, il va nous faire le point sur la prise en charge du cancer de la prostate métastatique hormonosensible. Donc, vous pourrez lui poser toutes les questions que vous voulez, en français ou en anglais. Je me chargerai de traduire et quand je n'arriverai pas à traduire, je demanderai à Karim de m'aider. Voilà, je vous remercie. Et Chris, je te laisse la parole. Thank you, Chris, to join us. It's a big honor.
The honor is all mine, and I'm going to share my screen and cross fingers. And I am hopeful that the full screen is showing. Are you seeing the full screen? Perfect, fantastic.
Yes.
Well, first of all, thank you very much for the opportunity to talk about a subject that's near and dear to my heart, metastatic hormone-sensitive prostate cancer. My goal will be to present all of the data from all of the study groups since Gwenaëlle first published and presented the GETUG 15. And what I just want to say is thank you very much for the wonderful collaborations over the years with the GETUG group. And it is my great honor to be able to return the favor with all the support that GETUG has provided. First of all, starting with the IceCap effort and sharing data from the different trials that GETUG has conducted that are as part of the IceCap repository. So thank you very much for that and the ongoing work we're doing now. And two, the wonderful collaboration with Gwenaëlle and Karim over the years as we think through metastatic hormone-sensitive prostate cancer with the different trials that we have been leading and thinking through the different ways forward together. The way I've structured this lecture is to try and put all of the findings in context and think of which may be the best patient population for upfront docetaxel versus the hormonal therapy approach. Also to think through the potential impact of where PSMA PET imaging may come into this. And I will throw out the controversial statement that I don't think it's that controversial, but it does lead to contention. Within any general population of a patient population with cancer, there are inherent subgroups. Just as there's heterogeneity in the disease, that can lead to different responses to therapy. Our challenge is to work out who those patients are, who may be better treated with a chemotherapy approach versus a hormone approach, and whether that can be defined by clinical subgroups or biological biomarkers is the subject of this talk. But what I do want to say is I think one thing that GETUG has done really well is actually annotate the patients in the clinical trials, and being able to go back to GETUG 15 and get 100% scan data was an amazing feat. And Karim has detailed to me the high quality that goes behind the scenes, which I've seen in the publication. So I want to say how much of a fan I am of GETUG. I'm also a fan of my slides moving forward on demand. Oh, they're not moving. There we go. First of all, I would like to declare my disclosures. I've been a consultant for a number of companies that make drugs and market drugs for prostate cancer, as one can see. I've also received research funding to support different projects, including the IceCap effort, and also the disclosure that I'm involved in the Charted study and the ENZIMET study, which may lead to some inherent biases. So first of all, let's just look at where we were in 2014, just as a stock take, an inventory. On the far right side is the purple, where we were doing all of our drug development and where all our standard of care was chemotherapy with docetaxel, cabazitaxel, abiraterone, alpha-radin, and enzalutamide, all the way on the right side. In the United States, we have access to the vaccine therapy, Sipuleucel-T, and the role of denosumab and zoledronic acid for bone prevention. That's where we were in 2014, but behind the scenes, as we know, GETUG was conducting trials in metastatic hormone-sensitive prostate cancer, trying to, in this space specifically. And I think that the reason for this is because GETUG 15 team and like myself was realizing, well, we've got all these therapies in castration-resistant prostate cancer, but how well are we really doing when we use these therapies for metastatic castration-resistant disease? Metastatic meaning conventional scan, so a large burden of disease if we're seeing it on a scan, and resistant. So we looked at the patients treated at Dana-Farber between 2004, 2007, cohort A, blue, and compared that with patients who had access to vaccines, hormones, radiopharmaceuticals, and chemotherapy, starting with the PSA greater than 1 as a landmark for everyone, the same starting point. And what one can see is that we really don't see much of a separation of the curve in patients with metastatic castration-resistant prostate cancer, whether they're dying of a disease other than prostate cancer or just chemo-resistant, hormone-resistant disease, despite access to all the new therapies, I think is quite likely. And there are just people who have very resistant disease, and we have not made much impact by using our therapies in castration-resistant disease. And then on the other end of the spectrum, with access to all the 5 therapies, we actually now see a 5-year survival going from about 12% to 22%. So there's maybe 15 to 25%. So not much of an impact on the median survival, but there are more long-term survivors with our new therapies. So the natural question is, can we go forwards by moving backwards, taking the chemotherapies and the hormones active in advanced disease to metastatic hormone-sensitive prostate cancer? So the question comes up, which agent should we use in metastatic hormone-sensitive prostate cancer? And what I propose is that we need to think it is like a chess-like strategy, because whatever we move first in hormone-sensitive prostate cancer impacts what we do for castration-resistant prostate cancer. So we need to think about the long game. But first of all, I want to address the elephant in the room about PSMA PET imaging. Here is my very crude overview of where PSMA PET is impacting and frankly leading to stage migration and lead time bias. So high-risk localized prostate cancer, by definition, nothing is seen on a CAT scan or a bone scan. But if we do PSMA PET imaging, we'll find a number of patients who will have minimal and extensive disease that's PSMA PET positive. And we know this patient population is potentially curable with local therapy, with standard radiation and surgery, with systemic therapy, hormonal therapy. Then there's the patient with the rising PSA post-prostatectomy and radiation. And we know some that will have none or minimal or extensive disease on PSMA PET. And then median survival with systemic therapy alone is about 8 years. Then within the category of patients with metastatic hormone-sensitive prostate cancer, I'd like to break it down into 3 different patient groups. Patients who have low volume disease, some of which will be oligometastatic because they will have disease that may be amenable to metastasis-directed therapy. But within low volume, there is the patients with more extensive nodal disease, maybe still 2 to 3 centimeters in multiple stations, but outside of a radiation field that's low volume and basically identifies patients with a good prognosis. And within that group, there may be more disease than seen on the conventional scan. And even within that group, there's the metachronous low volume, which we know has a median survival of about 8 years, similar to patients with a rising PSA post-prostatectomy, treated with hormonal therapy. And then there's the de novo metastatic low volume, which has an intermediate survival of about 5 years. Then there's high volume, by the definition that we created for the charted. And if you do PSMA PET, there may actually be more lesions than seen by conventional scan. And the metachronous high volume has an intermediate survival of about 4.5, 5 years again. But the de novo high volume are the patients who have ended up on most of the studies, and they have the worst survival with testosterone suppression alone of 3 years. And the reason I use the term testosterone suppression rather than ADT is because in 2020, I really don't know what ADT is anymore, because abiraterone and Lupron, or the GnRH agonist, is actually the ultimate androgen deprivation therapy, which is different to just testosterone suppression alone. And that's the reason why I'm passing this out, so that when the future generation come through, they actually know what I'm talking about at least. Then moving to M0 CRPC, we have patients, nothing on a CAT scan or a bone scan, but with PSMA PET, they may have uptake, none on a scan, uptake in the prostate bed, or where the prostate used to be, or with metastatic disease. And their median survival with placebo is 4.6 years, and then starting treatment at the time of metastatic event, castration metastatic event, or early AMID, they get about a year prolongation of median survival. I think we need to take stock of this so that we can actually understand our future trials as PSMA PET start to impact outcome. I also want to get this conversation off the table because it can be a bit of a distraction. And I just want to say, no doubt, PSMA PET identifies more disease than a CAT scan or bone scan, as I just showed. No doubt, however, is that we need to show how it improves patient care. And I suspect we'll have a lot of questions for this at the end of this talk about this. I do want to be very upfront and say, I personally do not think management change is a surrogate for better patient outcomes. I do worry about, does changing to systemic therapy alone in a patient who has high-risk localized disease on a conventional scan, but PSMA PET positive beyond the pelvic lymph node, compromise overall survival? This is my concern. This is what I have seen happen. Many of these patients who would be PSMA PET positive were enrolled on the trials of ADT and radiation, which we know is better than radiation alone, and we know is better than hormonal therapy alone. We also know that low-volume metastatic hormone-sensitive prostate cancer have a better survival in patients who got prostate radiation, even in the presence of low-volume disease on a conventional scan over testosterone suppression alone. And it's quite possible that those who have PSMA PET positive disease beyond the pelvic nodes may actually benefit from the intense systemic therapy added to the local therapy, is my conjecture, and one thing we need to look into. So I would propose their patients, we may want to intensify therapy with curative intent rather than de-intensify therapy. I also think PSMA PET will actually help us identify patients who may benefit, but we have to prove this, who may be from SBRT, either in the M0 hormone sensitive setting or in the M0 castration resistant setting. And it could be that low volume hormone sensitive by conventional scan, but more extensive disease on PSMA PET may identify those who benefit from docetaxel. And here is the basis for this data. And again, part of the collaboration with Gwenaëlle and the team at GETUG 15, we actually were able to look at the data set and show consistency, whether the study was done in France or in the United States. Patients with metachronous low volume, M0 at diagnosis, but then relapse with 2 or 3 bony metastases, have a median survival of about 8 years. Metachronous high volume and de novo low volume, about 4.5 years, and de novo high volume. So that was consistent with a study conducted in France and a study conducted in the United States on the testosterone suppression only arm. On the right is when we went back and looked at actually what was the distribution of these patients in the Dana-Farber Cancer Institute Hospital Registry. Again, we can see the outcome, metachronous low volume, de novo high volume, 3 years versus 8 years, a huge spread. And then there's this intermediate group. And I'm working on trying to see if we can develop a classification by getting all the individual patient data to maybe come up with a good intermediate and poor prognosis group so that we can think about this in the future, like we do with kidney cancer. Work in progress, we'll see how we go. What I would also like to point out is that most of the low volume patients within the Dana-Farber Cancer Institute were actually patients who had metachronous disease. So there's basically 200 patients, of which 210, of which 125 were actually metachronous low volume prior local therapy, prior prostate radiation and metastasis. So when we think about low volume, this is the de novo low volume is actually less than half of the patients. But I do think that the de novo low volume could be patients who behave like high volume, or they could be patients with an indolent progression like the metachronous, and they are in between, a watershed group. Also just want to look at this curve here and just show that patients with metachronous disease, as evidenced by rising PSA after prostatectomy or radiation, their median survival is longer than 8 years, whether they get intermittent or continuous androgen deprivation therapy. But let's realize 60% of the 524 deaths were not prostate cancer related. And this is the same outcome of patients with metachronous low volume. So these patients behave more like the rising PSA and clearly much different to the de novo conventional scan high volume. So let's look at the extreme phases of metastatic hormone-sensitive prostate cancer. On one extreme, we have the 55-year-old with no comorbidities and high-volume de novo metastatic disease, and let's say he's got liver metastases. And on the other extreme is the 82-year-old with congestive heart failure and coronary artery disease and 2 bony metastases 10 years after a prostatectomy, who's far more likely to die of something other than prostate cancer, and we need different treatment paradigms. This basically is a synopsis of what I'm going to talk about next and how I think about treating patients with metastatic hormone-sensitive prostate cancer. We should look at all of the data and compare what the signals are from the docetaxel versus the amide versus the abiraterone studies. We need to make a decision.
Chris, excuse me, can I stop you just a minute? Can you put your full screen, because it's a little short for the...
Full screen, okay.
Excuse me, sorry.
Yeah, you're in presenter display.
Is that right? Is that better?
Yeah, great, thank you.
Oh, sorry, I set it on the wrong one. Yep, got it. Thank you, Gwenaëlle. And please jump in if anything. Okay, so now my camera's slipping. Okay, perfect, thank you. Oops, now my camera's falling. Is this where someone starts singing London Bridge is Falling Down? Okay, sorry. Okay, thank you for that clarification. So, is a patient fit for chemotherapy? Is a patient fit for APA or ENZA, specifically no seizures and no frailty? Is a patient fit for abiraterone based on their diabetes, hypertension, liver function? Is there evidence of a consistent overall survival signal for a given use of a given agent, docetaxel versus hormone sensitive in given groups, preferably with no decrement in quality of life on therapy? And if chemo fit in high volume and not in a COVID pandemic, I can make the argument for you can give docetaxel either testosterone start or CRPC and alternate with the abiraterone or amide. And I actually make a proposition of giving docetaxel first when they're most fit, and they'll actually have less long-term exposure to abiraterone or an amide, less cost and exposure and the chronic side effects of these drugs, because they get the docetaxel and then they just get to the testosterone suppression alone with the survival benefit. But if a patient is chemo fit and low volume and not amenable to surgery or SBRT for metastases, at the time of testosterone start, we can see there's consistent evidence for the use of the amide or abiraterone in this patient population across all the studies. It's less consistent with docetaxel, and I'll show that. But if you don't give docetaxel in the hormone sensitive setting, don't forget about it in docetaxel in the castration-resistant setting. Oops. So here is just looking at all the data. It is very consistent that docetaxel improves progression-free survival regardless of volume of disease, high and low volume. Here's the de novo metachronous low volume in Charted. Here is the high and low volume together in GETUG 15, and here's the low volume in de novo metastatic disease. But in this setting where we've got patients who are living for 8 years or so, I think we need to think about it more like an indolent lymphoma rather than giving chemotherapy upfront automatically, because we have 2 data sets which combined, I think, provides relatively consistent evidence that the impact on overall survival is less and in patients with low volume disease. So here is the Charted and the GETUG data combined, both for the de novo low volume and metachronous low volume. And when you look at the numbers, we actually have about 273 de novo low volume and 191 metachronous low volume. It is interesting that the Stampede data set has a different outcome, but I would propose there are a few things that may not get highlighted as potential limitations. This was retrospective data where a urologist worked with a radiologist to look at the scans. They're missing 24% of the data, whereas the GETUG 15 team, congratulations, was able to get data on 100% of the patients. Even in the ASCO guidelines that just got published, they actually mentioned this data set is underpowered. And the notion that it was going to actually have a lot more patients for the analysis, they only report, the report is limited to those who got docetaxel, not the docetaxel zoledronic acid. And what one can see is it's 124 docetaxel patients in de novo low volume patients. So when you look at it all, I would say this is an outlier compared with the more consistent data with the more complete data from Charted and GETUG. And also, we actually have data from Stefan Haddad's present publication in patients with a rising PSA post-prostatectomy, again, like the metachronous low volume, and we see no evidence of benefit in radiographic progression or any strong evidence of benefit in castration, in overall survival with adding docetaxel to testosterone suppression in patients with rapidly rising PSA post-prostatectomy or radiation. And if we look at this all in data as a complete data set, we actually have, I've got GETUG 15 here because it was the first study. And I'm going to say it was the first study that showed evidence of a potential benefit. There were reasons why it didn't have the p-value less than 0.05, but I would actually say, as Gwenaëlle was very gracious in her introduction, that Gwenaëlle was actually the first one who actually led the front, but Gwenaëlle might be the most humble lady in the history of mankind and needs to be recognized, as François pointed out before we got on the call together. I agree with you, François. So here we have all M1 with everything going in the direction 0.88, 0.72, and 0.81 for all the M1 group together. We actually see a consistent signal of 0.78 for the high volume, 0.63 for Charted, and 0.81 in the Stampede. So a little bit less of a signal in Stampede, but again, recognizing they're missing 24% of the data, it's retrospective, whereas this is 100% of the data, smaller numbers. What's also very clear is the de novo low volume, when you look at it, the curves, they look like a hazard ratio of 1.0. It's 0.86. So it's not, I'm not saying in the de novo low volume there isn't a treatment benefit. I'm just saying it's not as strong and as consistent as it is with the hormones that I will show, when you look at it with prospective classification or when you have 100% of the data. And there is this outlier here that is p-value not statistically significant. The Stampede team makes note of the test for interaction and showing this group doesn't show a difference to their high volume in their study, So yes, if we had Stampede alone, I would say that is, there is a point for that test for interaction. But when we look at all the data, that data set is less convincing to me. We should also look at low volume metachronous, where we have a smaller number, but the hazard ratio is clearly 1.0. So I think we've got strong evidence not to be giving them metachronous low volume docetaxel. And there may be some patients, but it's not as strong as the Stampede signal would suggest in the de novo low volume. And it basically, it's not evaluated in Stampede. Gwenaëlle and the GTEC 15 team was able to get the aggregate data from Charted, and what one can do is actually do a very complete test for heterogeneity using as much data as we had. And what one can see is when you use the test for heterogeneity, which is this p-value here, one can see is that the high volume had a different treatment effect to the low volume patients. And we're talking about the combination of the pooled hazard ratio, where we have 513 high volume and 277 low volume patients. So this is saying they did behave differently between the two groups. The other thing I think we should take into account is the quality of life. Recognizing many patients with long-term, with low volume disease have a longer overall survival. And here we see low volume patients have a better baseline quality of life by FACT-P score than patients with high volume, which makes sense because high volume is more likely to have symptoms from the cancer. The low volume patients got side effects from chemotherapy and a decrement in quality of life, which was basically neutralized at 12 months. Whereas there was no real decrement on therapy for the quality of life for patients who got docetaxel high volume, but they had an improvement in quality of life at 12 months. So, and that's probably because you're balancing the baseline cancer symptoms against the chemotherapy side effects, and the patients actually may actually feel better on chemotherapy with better cancer control than the hormone approach alone. So here we don't see a strong, consistent survival signal for low volume, and we see a quality of life detriment. So I would say we have evidence for docetaxel in high volume, and less so for quality of life and clinical benefit and survival for low volume. Now let's move to the hormone-sensitive setting, where we have a very consistent signal in all the studies. Dr. Fazazi was first out of the gate with a hazard ratio of 0.66 with a fantastic plenary session in New England Journal paper. And then we see the abiraterone, basically all de novo again, having a clear signal in all M1, and a hazard ratio of 0.67 in Charted, Enzamet, where 45% of the patients got concurrent docetaxel, which may be diluting our signal, and the pharmaceutical study Titan having the same, with apalutamide having the same effect. And recognizing the median follow-up for Enzamet was an interim analysis of 33 months, and it was about 26 months for Titan. So this is very early data, so a very early signal, driven mostly by the high volume, high risk patients, 0.62, 0.54, 0.53, 0.68, recognizing again, this is early data. So this is early data, but very consistent. And we actually see a very consistent signal in the low volume, high risk patients, low volume patients across all of the study groups. So instead of seeing hazard ratios 1, 0.86 and 0.76, there's a very strong consistent signal with the hormone approach across all of the low volume group. We have no data for abiraterone in the metachronous setting or with Stampede abiraterone basically, but we're starting to see a signal for prior local therapy with enzalutamide and apalutamide. This was M0 at diagnosis. In the New England Journal, we report prior local therapy, which may include radiation for low volume disease. What I'm doing now is passing out the M0 diagnosis and then relapsing the metachronous low volume, and we'll be able to report that. But we're actually seeing for the first time a group, this metachronous low volume, who may be getting a benefit from the intensification of upfront systemic therapy. Granted, both cross 1.09, but on aggregate, it's consistent in going in the same direction. So I would suspect this would play out for enzalutamide as well. for abiraterone as well. Often, I will not dwell on this because I know the audiences are experts. The question is, do we use an amide approach or do we use abiraterone? And it comes down to the toxicity profile, as I mentioned before, which patient can tolerate a corticosteroid and the liver dysfunction versus the risk of frailty and seizures with the amide. You're all experts and I won't dwell on that. We should also recognize we should not forget about radiation to the prostate in patients with metastatic low volume disease. And that should definitely be in our algorithm, especially if you cannot access hormonal therapies, the abiraterone or the enzalutamide for whatever reason. And this is a data set that I would actually give credit to Karim for pointing out first. I'm very confident if a patient is chemofit and has liver metastases, we should be focusing on a chemotherapy approach. We see a signal for visceral metastases in the CHARTED study, but we do not see that signal with, as Karim pointed out for the first time, in Latitude. And then we don't see that signal again in Titan or enzalutamide. So if a patient is chemofit, I would double down with docetaxel up front based on this data set. Granted, it's limited, but we've got to make use of the data that we have. So I know it's controversial, but I think this is my high-level summary. GETUG 15 was the first study conducted. It was a smaller study, but I think it's all very consistent and was the first study to show a suggestion of a benefit. Well done, Gwenaëlle, again. The Kaplan-Meier curves for de novo low volume are overlapping with CHARTED, and well done on being able to look at all the data set. The outcomes of the low volume and high volume groups are homogeneous with CHARTED, and there's a consistent signal of a less and possibly benefit with docetaxel. CHARTED was the only study with a prospective stratification by volume. Stampede is missing data on 24% of the patients in a retrospective analysis and does not include metacrinous low volume. But the bottom line is there are probably some patients with low volume de novo who benefit, but it's not large enough to see a clear treatment across all trials. And some patients with high volume probably don't benefit to chemotherapy, and we need biomarkers. But it's also very clear we do not know if there's a treatment effect of any sort of adding docetaxel to low volume in patients who have radiation to the prostate with low volume de novo metastatic. So here is our first shot across the bow of our first effort at trying to get biomarkers from CHARTED. Here is the PAM50 gene expression profile done by Decipher from the prostate specimens. And this is the same basal versus luminal B that we see in metastatic, in breast cancer. And here we see basal, where we suggest no benefit, a suggestion of no benefit with docetaxel, but a clear benefit for luminal B with docetaxel. This is not definitive, but it's a very intriguing preliminary hypothesis generating result. And on the flip side, Dr. Felix Feng presented for Titan, showing that docetaxel, so apalutamide, potentially had a survival benefit, RPFS benefit with basal, but not luminal B. But the bottom line is we have an international collaboration merging with funding in place, working with Decipher to see if we can look at this between Stampede, Enzamet, CHARTED, and potentially Titan, and hopefully GETUG if the samples can be obtained. We also have evidence that patients with the germline SNP in HSD3B1 with a variant allele, the yellow curve, which makes more extragonadal androgens, have a poor overall survival with testosterone suppression alone, whereas we did not see that separation in the group that got a docetaxel benefit. We plan to follow up on this analysis in Enzamet, and maybe these are the patients with low volume who benefit from intense AR inhibition. But I think we've got work to be done, and data will be flooded with data quite soon. I just want to be very clear that Enzamet is a mixed bag, high and low volume, de novo and metacrinous. About half got concurrent docetaxel, and like the piece 50, and we've got a first evidence of clinical progression-free survival, but with an early analysis, we do not see a survival benefit. But on the flip side, we see both a clinical progression-free survival with enzalutamide alone and an overall survival benefit. We need longer-term follow-up data to make a conclusion here. And we will have that. And I think by having a collaboration and looking at all the data, we'll be able to look at those who got prior docetaxel in Titan, also within Arches when they have their survival benefit. The ARASENT study of AET dosi plus or minus darolutamide will have strong data hopefully soon. And the Piece 1 effort, where the amendment to allow docetaxel, will have about 750 patients. So we will have more than 2,000 data, hopefully by the end of 2021, early 2022, of whether the triplet therapy is beneficial for patients who were chosen to get docetaxel. So here is my final conclusion of how I think we should think about prostate cancer. Chemofit, high volume, all of the options are reasonable. Not chemofit, high volume, ABI, APA, ENZA. Chemofit, not chemofit, low volume de novo metastatic. Strong signal with ABI, APA, ENZA, or Regi at the primary. Mixed results with docetaxel. Chemofit, not chemofit, low volume prior local therapy. Metacrinus, if you would. We see a signal with APA and ENZA, but I suspect we would see it with ABI as well. And I thank everyone for your attention.
Thank you very much, Chris. It was a very great talk, and I have a lot of questions, but I'm waiting for the question on the chat. So, Laurence, you know well Laurence.
Yes, Dr. Albiges.
She's
Hi,
here.
Chris. Thank you for
Hello,
being
Laurence.
here today.
So, she asks you, in metacrinus low volume, what is your strategy?
My non-evidence-based strategy is I will treat the bony metastasis with SBRT if it's within a radiation field. I have been doing this for quite a while, and I've been giving 2 years of testosterone suppression therapy and stopping therapy. And I have a number of patients who have been off hormonal therapy for 5, 6, 7 years without any recurrence. So my approach is SBRT with a course of hormonal therapy. If they're younger and they're fit enough, I would actually add chemotherapy, so enzalutamide to that. So an intense 2-year therapy of SBRT plus with 2 years of Lupron plus enzalutamide, for example. Do I have data to support that? No. Do we need a clinical trial to confirm or refute that? Yes.
Are you doing intermittent enzalutamide?
I would stop.
This low volume disease?
I stop at 2 years and see if we've actually had a great benefit. If a patient's not tolerating the enzalutamide, I decrease the dose or I stop it if they have a very good response. I think one of the most important studies to be done is, can we do a treatment break, maybe even stop therapy altogether for a long time, maybe forever in some patients, if they have a PSA less than 0.1 at 12 months. And my colleague, Dr. Chowdhury at Dana-Farber, is trying to get a trial going through the NCI with Alliance. It'll be, I think, stopping therapy after 12 months if a PSA is less than 0.2.
Okay, thank you.
In high and low volume.
High volume also?
Yeah, if they're in a great response.
Karim is asking you, what is your bet regarding trials looking at triplet versus doublet?
So is it my bet, my wish, or my hope? I am hopeful we will see a strong survival signal in patients with high volume disease. We see a strong clinical progression-free survival, as you saw, but I'm encouraged by the fact that with Stampede abiraterone, the survival benefit actually got wider. The curves splayed apart even further in longer-term follow-up, to suggesting that chronic long-term AR suppression may actually add to the benefit with docetaxel. So to what was achieved early. So maybe the long-term control will actually add to the control with docetaxel. I don't know. I hope. I will put 5 franc of Kroom's money down on that. I'm a big spender.
François, in case of low volume de novo treated with RDT, yes, he asking you RDT, radiotherapy, and hormonal and new hormonal therapy. do we have to carry to the treatment all lifelong? But you already give a response, so
yeah, for sure.
2 years.
We need to do the trial. I think GETUG would be a fantastic organization to lead that trial.
Yeah. And what do you think about the patients who had PSA less than 4 at 6 months, or PSA increase? Do we have to work on this population? I think it's a very high risk population.
For sure. 2 things. Yes, so we see they have a very poor prognosis overall, especially when we didn't have routine access to abiraterone or enzalutamide for castration-resistant disease. I think we definitely need to try and intensify therapies. My pet peeve is that we develop all our advanced therapies for castration-resistant disease, but I think that with all the new therapies we're developing, whether it be an EZH2 inhibitor or these other targeted therapies, we should be using it at that stage to either prevent that resistance or try and reverse it at that stage, rather than when they've got late-stage metastatic castration-resistant prostate cancer. This is a problem with drug development, but I agree with you, Gwenaëlle. They are a special patient population who declare their poor outcome early, and we need to intensify their therapy. I don't know how.
It's like high variant aggressive disease. We need to define before, at the time of diagnosis, it's high variant aggressive disease. Paul Sargos is asking you, so regarding recent data for you, metastatic directed SBRT is a level 1 evidence and can be proposed out of a trial?
Paul, I don't think it's level 1 evidence. It's what we wish and what we have as level 1 evidence are often 2 different things, but we sometimes conflate them. I would say Oriole and STOMP are very, very encouraging data sets, very, very encouraging data sets, but nothing that is definitive. And it really does support doing a clinical trial. For low volume de novo metastatic, I think the trial is intense hormonal therapy plus or minus SBRT. And I know Pete Ost and the NRG Fu Trang are proposing SBRT plus or minus hormonal therapy in the metachronous low volume. I think they're great questions and they both should be done. What do I do for my patients right now? I do the very aggressive approach, hoping that I can get, especially if they're very young, with the hope and wish that they will get a long-term off hormonal therapy, as I have some patients like that. You're welcome, Paul.
We have a French trial.
Oh, of course you do. Leading the way again.
It's a Pierre Blanchard study. Karim asking you, do you routinely recommend germline BRCA screening in your patients with upfront metastatic disease?
So, and even for Laurence's question, so we do send off a germline panel data set in patients with high-risk localized or metastatic disease. Depends on your patient population. Probably in a large urban setting where there's a background population of Ashkenazi Jewish immigrants to, say, Boston or New York, the rate may be higher, closer to 10, maybe 5%. Whereas if other regions of the world, it may be closer to 5%. But that rate is high enough, even if it is 5%, as low as 5%. And I don't do it solely for identifying potential future therapies for the patient. It's for the cascade testing for the family for breast, prostate, pancreas now, for BRCA and all the other ones. So I think we need to be much more aggressive in identifying patients who would benefit from earlier identification with germline testing.
Antoine, Thierry Villemain is asking you, imagine that triplet trials are negative. Which biomarker might help to choose between chemo or new hormonal therapy? PAM 50, PAM 50, or what kind of biomarker?
The biomarker that I'm most encouraged by the preliminary data we have is the liminal B versus basal, and there's some preclinical data to support that. We see a strong suggestion in the subsets from Charted and Titan. So I'm doubling down on that, Antoine. But you're right, the problem will go away if the triplet works, won't it?
Laurence, do you is the age influence your strategy in low volume disease all the time? Or?
Yeah, so I would de-intensify. So if it's an 82-year-old who's got the multiple comorbidities, I might just do if it's easily accessed with radiation, I might radiate them. I look at what I think their projected life expectancy is outside of the prostate cancer. So a very old person with lots of comorbidities, less is more. Yes. Well, no, just frequent dosing, not high dose, that's toxic, but frequent French Burgundy or something from the Rhone Valley. No, we don't want to be doing shots of tequila. That's just dangerous.
So, no, Karim is a joke, so that
that's what I was responding to.
So no, I give you the information later. You agree, Karim? So can we have some more? We can ask him some more question. Yes. Do you use luminal B to choose the treatment for your patients?
Not yet. No, gosh, no. I basically, we've got funding to try and corroborate that, and we're doing whatever we can to do that. So the question from Adelaide, that's an interesting one. Just want to say, I grew up in a town called Adelaide, so that name is very special to me.
I have to say the question because everybody don't see the question. Do you think that PSA can be a surrogate?
I'm hopeful. So what we are doing right now, Adelaide, is we're getting all the data from as many trials as possible, from GETUG, Stampede, Enzimet, all of them. And the StopCap MRC team is getting all that data into one database. And then we're getting that data to Susan Harvey to see if we can use it for a surrogate for overall survival, as well as doing this. And the MRC is going to do treatment effect, and the Susan Harvey and myself and her team are going to look for, can it be used as surrogates for overall survival to expedite clinical trial conduct? It's a work in progress. And we're doing similar work with the localized diseases many people would know. And GETUG is contributing that data set as a fantastic collaborative organization. So thank you for that.
Welcome. I like you use testosterone suppression than castration. For the patient, it's better also to use this term.
You know, let's keep sharing that word. Thank you.
Laurence, where do you see PARP inhibitor local? Where do you see PARP inhibitor localized setting? Okay.
I would actually, so where do I see a role for PARP inhibitor?
Yeah,
I think it's a clinical trial for anything outside of castration-resistant prostate cancer. There's actually emerging evidence that maybe there is some DNA damage in M.B.B.S associated with some long-term PARP inhibition. Whether that's associated with prior anthracycline or radiation in breast cancer, I don't know. But I would say you should use our standard therapies with prolonged survival demonstration in hormone sensitive and localized, and reserve PARP inhibition for castration resistant when they need it as a chess piece for later. But we should definitely get the biopsy, genomically profile the germline and the tumor to see if it's a chess piece we can use later. I am not using it in earlier stage disease.
And what do you think to looking at the PTEN loss to all patients and to try to do selective treatment, so personalized treatment for upfront metastatic disease, maybe?
So
PARP inhibitor, PTEN loss, and
I think the PTEN loss, I'm not convinced about the data about PTEN loss and PARP inhibition data, but I do 100% think the study of the kappa verticid plus or minus the AKT inhibitor and PTEN loss is very, very important. And it has to be done. We've got some very promising and encouraging results in castration resistant. We just need to improve upon the biomarker selection, I think, to work out who benefit from it. But we're definitely going in the right direction. And we need to prove whether it has a role in metastatic castration, in hormone-sensitive disease before we roll over it. So I do not use any biomarker for treatment selection in metastatic hormone-sensitive. I do think we've got enough guidance from the clinical subgroups of which one has the consistent survival and quality of life data to use right now.
And what do you think about the using lutetium in earlier in the disease?
I think it really needs to be done as a study again. I would not do it off protocol. We need a clinical trial. One is, can the hormonal therapy actually decrease the PSMA PET positivity if they're responding? And there is some evidence of that. And so you may actually give the lutetium PSMA without actually getting it to the tumor if they lose the PSMA when starting with hormone sensitive. And with the we're using the gallium dotatate equivalent in the neuroendocrine, where there's years of survival. They're starting to see MDS and leukemias develop in those patients. Again, whether it's related to their other therapies or the dotatate, unknown. But we cannot dismiss the chance that the use of these genotoxic agents, PARP inhibition, lutetium PSMA, may actually have downstream effects years later, like we saw with anthracyclines, especially when we're having patients living 8, 10, 15 years in hormone-sensitive states, or especially in the localized curative setting. So I'm not doing any of this outside of a trial. Okay.
So I think we need to cut. I'm so sorry for that, but Samra Turajlic is here, I think. Laurence, I need to leave. It's your turn.
No, you stay around. You stay around.
Okay.
Please.
So,
Chris, thanks again.
Chris, you can stay.
I would love to. I've got a meeting with Samra's colleague at 9 o'clock my time with Dr. Atan to work on that biomarker work. Nice to see you, Samra.
Sounds like a better use of your time, Chris, than listening to me. So.
Oh, gosh, no, Samra, I was disappointed. All the best, everyone. Thank you very much for the kind.
Thank you very much. Thank you for your time. Thank you for your answer, and for next study together.
We stay in touch. Au revoir, everyone.
Au revoir.
Thank you, Chris. So it's now my pleasure to welcome Samra Turajlic. Samra, we're really pleased to have you. As you know, we are trying our best in France as well to move forward the field of RCC using biomarker. And you have built a huge seminal work in understanding RCC biology, especially the heterogeneity, but also onset of resistance. So we would like to hear from you on how this biological work is actually more and more maybe getting us to the treatment decision strategy, especially in an era where we have more and more treatment available, IO, TKI. Thank you, Samra.
Thanks very much, Laurence. And apologies in advance to everyone. You'll probably end up getting a bit more science than you bargained for. But I think the question about the choice of first-line treatment, especially now that we have this embarrassment of riches, really has to take us back to the biology and all the conundrums that clear cell kidney cancer presents. But I'm very happy to discuss the more practical questions about the choice of therapy in the Q&A after. I'll just share my screen. So you can see that okay, and I'll go to slideshow.
Perfect, thank you.
Okay, so here are my disclosures just for completion. Most of the work we've done today really concerns the sort of molecular evolution of kidney cancer. So definition of canonical genetic drivers of kidney cancer, copy number variants that drive kidney cancer, in which way all these events combine in order to drive different clinical phenotypes. But those data were already published almost 3 years ago now, so I really don't want to go back to that, and I'm hoping to share with you today some of the more recent insights that perhaps feel a little bit closer to the clinic as well. And the reason for that is that in spite of the work that our and many other groups have done to contribute to the molecular understanding of kidney cancer, that seems to be a huge bottleneck in terms of translating that into valuable biomarkers in the clinic. So perhaps in the therapeutic setting rather than a prognostic setting, we might be able to get to somewhere. But again, I want to come back to this fundamental question of immunogenicity in clear cell kidney cancer. So it's well established that kidney cancers are highly infiltrated tumors, and very specifically clear cell. So I want to draw your attention to this graph, which is an analysis done some years ago now of an aggregate T cell infiltration score across 20 different solid tumor types. And you can see that clear cell kidney cancer is right up here. So it is the most highly infiltrated solid tumor. Is this a tissue specific process? Well, from these data, it doesn't seem to be, because papillary kidney cancer is down here. Is it driven by mutational processes? So we've got these highly mutated tumors such as melanoma and lung cancer up here. But, again, we know that kidney cancer doesn't quite fall into that category. So this slide leaves us definitely with more questions than there are answers. So what are the conventional sources of immunogenicity that tumor immunology community thinks about? Well, neoantigens have been very in vogue for a long time by virtue of the ease of their measurements from mutational data, and of course functional studies that show that many of the T cells that infiltrate into tumors, when I say many, up to 1% of CD4 and CD8s are reactive to specific neoantigens, and these neoantigens do arise from mutations that lead to mutant peptides. And I'll come back to that in a moment, but of course it's a very learned audience. You don't need any reminders of the history of IO in clear cell kidney cancer. But of course, all these contribute evidence to the fact that RCC is an immunogenic cancer. So we've got instances of spontaneous regression, the previous era of immunotherapies, immune checkpoint inhibitors, and of course now combinations of CTLA-4 and PD-1 and PD-1 and VEGF TKIs. But again, none of these studies to date have given us any hints as to the antigenic source that elicits these responses. So what about mutations? Well, I'm sure everyone has seen this slide ad nauseum. It gets shown at every single meeting about IO in the context of any solid cancer. But again, it goes to the point of highlighting the outlier nature of kidney cancer in general. So responses to if we just think about PD-1 in kidney cancer are akin to responses seen in lung cancer. But when you compare the tumor mutational burden, which is sort of in this mid-range, much more akin to ovarian and prostate cancers of conventionally immune cold tumors, than it is to lung cancer. So again, there is this disconnect between what we think drives the immune response and what we're actually seeing in these cancers. And the reason why tumor mutational burden is generally associated with response to immunotherapy is because formation of neoantigens is a probabilistic process. So the more mutations there are, the greater the likelihood that there will be a mutation that will result in just the perfect peptide that will bind with increased affinity to MHC class 1, therefore it's more likely to be presented on the cell surface and interact with the T cell receptor. And the more different that neoantigen is to the native peptide, the more likely it is to have escaped central tolerance and therefore result in a T cell reactivity that drives an efficient immune response. So if that is a probabilistic process, then it seems unlikely that is the process that drives such high degree of infiltration by T cells in kidney cancer, given that there are fairly few mutations present in these tumors. But it's worth noting that tumor mutational burden as a conventional measure really reflects point mutations, so changes in just a single nucleotide variant. And the reason why this is how we read tumor mutational burden is very practical. Point mutations are the most abundant mutations in the genome. They're very easy to measure from next generation sequencing data. The issues around, technical issues around calling them and quantifying them are very limited. However, it does overlook other sources of potential neantigens. So, for example, translocations are increasingly recognized as potent neantigens and can result in different neantigen peptides that are presented to the immune system, and translocation to different malignancies are now taking advantage of that finding in terms of CAR T therapies, as well as biomarkers of response to IO. Of course, there are lots of modifications that happen to peptides after they're translated. So those post-translational modifications can also change what happens. But one thing that intrigued us was another class of mutations that potentially result in highly specific, tumor-specific neantigens and potentially a high number of novel neantigens. And these are frameshift mutations. So what happens in the context of a point mutation is that just a single one of the amino acids will be changed if that's a non-synonymous mutation. And this is the interaction between the peptide and the MHC class 1. We know that in this interaction, there are particular residues that are very relevant, residues 2 and 9. So you can see that depending on where your mutation falls, the interaction between the peptide and the MHC class 1 could be completely unaltered by a point mutation. However, if you consider what happens with a frameshift mutation, where you potentially are changing every single amino acid, suddenly you're really influencing that interaction. And what's more, you're influencing the likelihood of escape of this particular neantigen from central tolerance and likelihood of activation of immune response. And indeed, we showed in a pan-cancer analysis a number of years ago now that for a given mutation, a point mutation will reveal far fewer potential neantigens than a frameshift mutation. So there is a very high enrichment, just even for a single frameshift mutation, for a number of potential neantigens. So this certainly gave us hope that we should explore this class of mutations further. And one of the things that then came up as a sort of a natural limitation for frameshift mutations is that they trigger this process of nonsense-mediated decay. And the reason why that happens is that if you change the open reading frame, the sequence will very quickly arrive at a premature stop codon, apologies, and that will trigger this process of nonsense-mediated decay. The transcript will be removed. It will never have a chance to be translated into a peptide. So no matter how good a frameshift mutation you have, it will just never have a chance to be seen by the immune system. So Kevin Litchfield, who was then a postdoc with us, subsequently has become a group leader at UCL, took on this task to show that if we incorporate the knowledge of nonsense-mediated decay into our prediction, and this is now in the context of melanoma, we're highly confident of predicting the response to immuno-oncology agents. And this is both in the context of T-cell therapy as well as immune checkpoint blockade, by taking into account frameshift mutations that we predict will escape nonsense-mediated decay, therefore will be translated and presented to the immune system. And one thing that really excited us about this is that it appears to give an opportunity to rescue those low tumor mutational burden patients who in certain settings, such as lung cancer, for example, where TMB is now being used as a cutoff for who should receive therapy and who shouldn't. The measurement of these nonsense-mediated decay escaping frameshift mutations rescue these patients back into benefit. So what this graph here is showing is the likelihood of clinical benefit in patients who got low tumor mutational burden, which could have excluded them from having therapy. And just having one of these mutations increased the likelihood of response fourfold. Now, when we first saw these data, we were a little bit incredulous how the presence of a single mutation can really alter the likelihood of benefit so much. But the rationale for it really lies in the fact that once you alter the open reading frame, you could create many, many different peptides. These could run into very, very long novel open reading frames where you can then get a multitude of peptides, 10, 15 novel peptides that can stimulate an immune response. So one frameshift mutation could be very powerful indeed. So what has this got to do with kidney cancer? Well, at the time when we conducted these analyses, we were also interested in just looking at how common frameshift mutations are in cancer. On the whole, they're not very common at all. It's a much rarer class of mutations. And on the median number of frameshift mutations that a solid tumor might have is only about 5. So the dynamic range is very narrow. But we were intrigued to see that on top of this graph were kidney cancers, and actually kidney cancers of all different histologies. So here's clear cell kidney cancer, papillary kidney cancer, and chromophobe kidney cancer. And relative to all other solid tumors, they appear to have the highest frameshift mutation burden. So quite different to that point mutation burden where they're somewhere in the middle. They seem to really top the scales with the frameshift mutations. Now, why is this remains really, really cryptic. It does appear to be a tissue-specific process because, as you know, clear cell kidney cancer arises from the proximal tubule, as do the papillary kidney cancers. But then you've got chromophobe, which has a different cell of origin in the distal tubule. So it's possible that there is something that's physiologically relevant here to the function of the nephron that causes accumulation of frameshift mutations, which are then subsequently not efficiently repaired. Of course, the other possibility is that these tumors might have deficiencies in repair of frameshift mutations. But given how distinct the molecular landscape is between clear cell and papillary and chromophobe, there isn't really a unifying molecular mechanism of deficiency in DNA repair to explain this. So our bet currently is on a tissue-specific process that perhaps is linked to the physiological role of the kidney. Since we published this, there have been other studies, actually, in addition to this one, that indeed have shown through whole genome sequencing as well, that this burden of frameshift mutations is indeed true for kidney cancer. So does it make a difference to immune response? Well, at the time when we published this, there weren't really any published studies of immune checkpoint blockade treated kidney cancer patients. But what we were able to correlate here in RNA sequencing data is the burden of frameshift derived neantigens, then balanced for the same amount of neantigens, but the ones that are arising from just point mutations, or ones that arise from insertions or deletions that don't lead to the shifting of the open reading frame. And as you can see here, only the frameshift originating neantigens drive correlation with CD8 T cells and also with cytolytic activity. So this gave us a hypothesis, if you like, that frameshift mutations could be contributing to that profound infiltration by T cells that we see in kidney cancer. However, there is so far no evidence of association, obviously, I've already mentioned, between tumor mutational burden, but also indels in kidney cancer. It's unclear at the moment whether this is to do with the size of the data sets, although I think some of the more published data, the more recently published data sets in the last 12 months or so have really given us very robust sense of the lack of the association, or that the antigenic source is in RCC is completely different. One of the technical things about determination of frameshift mutations from genomic data is that it's much trickier than point mutations. So there are possible other caveats. In my opinion, I think it might be both. So we've not completely written off frameshift mutations as the potential source of T-cell reactivity in kidney cancer. And one thing that sort of gives some rationale to that hope is the data from this vaccine trial that's almost more than 10 years old now. So as you know, VHL is a canonical driver in kidney cancer. It's a tumor suppressor gene, and therefore invariably mutations in VHL tend to be frameshift mutations because that's how tumor suppressor genes are inactivated. So the investigators in the study took advantage of the fact that the VHL mutations were specific to the patient, and they created the peptides that match the frame-shifted peptides that would have been created by the mutation. And in a good number of patients, they saw a positive reaction by T cells, which was tumor-specific, and indeed a durable response that was driven by this VHL frame-shifted peptide vaccine. So I'll come back to this perhaps later in questions, but this remains an open question in my mind. So another thing that's another potential source of immunogenicity that's emerged so very broadly in solid tumor oncology are these non-coding epitopes, endogenous retroviruses. So these are ancient viral genomes that integrated themselves into the human genome sequence long time ago, and therefore they're inherited. They are normally transcriptionally repressed. So they should not be transcribed, they should not be translated, and therefore there should not be an opportunity for them to be presented to the immune system. However, as you know, regulation of transcription is one of the things that's heavily dysfunctional in solid cancers in general. And if we think about kidney cancer in particular, many of the mutations in kidney cancer that follow on from VHL, so mutations in PBRM1, in SETD2, in BAP1, affect chromatin modification. And it's the conformation of chromatin that really directs accessibility of transcriptional sites for binding and initiation of transcription. And therefore, it's perhaps not surprising that in kidney cancer, we do see highly elevated expression of endogenous retroviruses that perhaps should not be expressed in the normal tissue. And this was a study that was done in a pan-tumor manner a couple of years ago, showing that these non-coding regions could be a very important source of targetable tumor-specific antigens. So I just want to, having sort of outlined the potential questions, I want to show you how we went about trying to answer them in the context of this prospective clinical trial, which was a phase 2 study of anti-PD-1 therapy. We originally saw this as a pre- and post-operative therapy in resectable metastatic renal cell cancer, and had mandated that only patients who were deemed suitable for a cytoreductive nephrectomy should enter the study. And subsequently, due to poor recruitment but a need to really meet the biological endpoints of the study, we opened it up to all comers. These are the data that I will go through with you at the moment. So the eligibility criteria were advanced or metastatic RCC with a clear cell component. We did not include patients that needed an immediate nephrectomy because we really wanted a period of time on nivolumab so that a nephrectomy is carried out. We have that rich source of tissue for biological endpoints. And as Laurence had alluded to earlier, a lot of our work over the years has really been around understanding of the impact of intratumor heterogeneity biomarkers. So we really wanted to have the spirit of that understanding and framework within this study. So wherever we performed biopsies, they were multi-regional biopsies, and if we were obtaining fresh tissue subsequent to cytoreductive nephrectomy, we ex vivo then sampled that tissue in a spatially disparate manner. Of course, you'll know, and if there are any radiologists in the audience, especially, that when we are sampling, when we're performing multi-regional sampling via image-guided biopsy, that can't be nearly as spatially resolved as it is when we do it ex vivo. So please bear in mind that the sort of the capturing of intratumor heterogeneity in these circumstances is likely to underestimate intratumor heterogeneity as a whole. So these patients received nivolumab for 9 weeks before having a protocol mandated multiple biopsies of both the primary tumor and metastatic sites where that was feasible, and then also at progression of disease and also at any surgical resections as well. So we were also able to supplement that with autopsy sampling in 3 of the patients. And in each of these instances, we had bulk tissue, and we also had tumor-infiltrating lymphocytes. And then from the bulk tissue, we could do DNA and RNA profiling and conduct whole exome sequencing, RNA sequencing, TCR sequencing, again, supplemented, cross-validated with multiplex IHC and IF work. And from TILs, we were able to look at flow cytometry and single-cell sequencing. Now, today, I'll really just focus on whole exome and RNA sequencing, and perhaps if there is another opportunity in the future, I'd be happy to come back and talk about the other aspects of this. Now, this is an extremely small cohort, you'll notice, only 15 patients in total. But again, the spirit of this study was really about biological endpoints and the number of sort of omic analyses that we could carry out. The balance of IDMC risk groups was adequate between these different groups, and we had a sufficient number of responders to look at the biological signal within this, at least for hypothesis formation. And this is really just to show you the kind of totality of samples that were used in the end. And again, the intention here is to be very comprehensive, but ultimately descriptive, I think, because all of this will then need, any signals will need validation in much higher cohorts. And we defined response as a durable, either stable disease or PR, and durable at 6 months or more. We did have a couple of patients that had a PR that was short-lived, and they were categorized as non-responders in that upper group. So this has been work led by a number of people in my group, and also collaborating with a basic immunologist at UCL, Sergio Quezada, and his fellows. So just to start us off, we see immune infiltration at baseline in both responders and non-responders. And I think that this is not surprising, because as we outlined at the beginning, all kidney tumors are highly infiltrated, and yet not all of them respond to immunotherapy. So we certainly were not surprised to see this. So what about heterogeneity? Well, actually, we do see that there is some disparity. So, for example, here is a patient where we were able to obtain a number of samples, and as you can see from this heat map, there is some disparity between the expression of different immune cell lineages between these sites. And of course, Laurence has published some time ago now about things like PD-L1 in primary and metastases comparisons. So again, this kind of divergence is not surprising. But in other instances, and I think on the whole, bearing in mind we didn't do very wide spatial sampling, on the whole, the immune infiltration signatures seem to agree across the small number of samples within a patient, which was encouraging. So what happens post-treatment? Well, we don't actually see a difference between the number of CD8 T cells. Again, nivolumab seems to increase the number of CD8 T cells, irrespective of whether it actually results in a clinical response or not. But what we do see is a higher granzyme B signature in responders post-treatment. So this is telling us that these are activated T cells. So there is, I think the interpretation of this is that nivolumab does lead to some non-specific T cell infiltration, but where that is tumor specific and leads to a meaningful clinical anti-tumor immune response, we see activation of those T cells as shown by granzyme B upregulation. So next we looked at T cell receptor sequencing, and we were really motivated by emerging data in other tumor types. So what would we expect to happen to the T cell receptor landscape under IO therapy? So these are some of the data that are out there. So this is triple negative breast cancer, for example, and that was reported as showing higher T cell receptor clonality in responders. So that means that there are fewer TCR clones present at the beginning of treatment. And I think that speaks to the fact, again, that there is an antigen presented by the tumor that is leading to clonal expansion of very particular TCR sequences. In the absence of that antigen, the TCR sequences are very diverse, and therefore there isn't a predominance or expansion of any particular clone. These are data from squamous cell, so this was in skin, basal and squamous cell carcinoma, and there was more replacement. So following PD-1 treatment, there was replacement by new TCR sequences into the tumor, suggesting that it wasn't necessarily the TCR sequences that were pre-existing, certainly in this context, that were driving the response. And then finally here, and apologies, I can't quite remember what tumor type this was, but there was retention of highly expanded clones. So there was higher clonality to start with, but following PD-1 treatment, those clones were also retained. They weren't replaced. So slightly conflicting data between these two studies. So what we find in the context of our cohort is that there is an overlap of expanded clones between time points in the responders. So first of all, there is a higher clonality to start with in responders, but we also see that post-treatment, there is retention of those expanded clones in the responders relative to non-responders. We also see that post-treatment, again, so that's shown in blue here, in the responders, those expanded clones are much less likely to be replaced relative to what we see in non-responders. So again, this is telling us that there is something driving the TCR response. We also see that expanded clones pre-treatment display more structure in responders. And really what the structure tells us is that they're likely to be responding to a similar or identical antigenic source if they're more related clones. So again, this is still building the argument that there must be an antigen that's driving this. So just in brief summary of this part, TCR sequencing shows us that there is an expansion of TCR clones that then persists through presumed antigenic stimulation, and that this associates with nivolumab response. But what is this driver? Well, this is the tumor mutational burden between the groups, including the indel burden. There is no difference. In terms of the molecular profile, and of course you'll be aware in the literature there have been reports of some mutations such as those in PBRM1 that differentiate between responders and non-responders, and there is a biological rationale for that because of the link between PBRM1 and interferon signaling. However, we really don't see that, albeit in this tiny cohort. We do see a tendency for much higher levels of chromosomal instability. So these red and blue bars at the bottom here are all copy number alterations that we see throughout the genomes of these individual tumors. And this does have a biological rationale because we know that generation of aneuploidy leads to extranuclear DNA being sensed by the CGAS STING pathway, which then can lead to upregulation of interferon signaling. This is now very contentious because we know that functionally this is what can happen. But if you look in the literature over the years, aneuploidy and chromosomal instability have always been associated with immune evasion, and therefore you would posit lack of response to IO. And therefore there might be something in the timing of aneuploidy as well. It might be that if high levels of chromosomal instability are present for long periods of time, that tumors become sensitized to the CGAS STING signaling. So this is very much an open question, and I really don't want to attach too much meaning to it just now. So what about those endogenous retroviruses? So colleagues in the field have already published around this. So first of all, we know that in a kind of generic study that was done some years ago now, the ERV expression can associate with T-cell infiltration and cytolytic activity. Then there have been a couple of studies specifically in kidney cancer and specifically with PD-1 that have associated certain signatures of endogenous retrovirus expression with nivolumab response. And then what's relevant to all of this, and again, I'm sorry to get a little bit technical, is that there are millions of these endogenous retrovirus sequences, and they're very difficult to align because they're in the non-coding genome, which is not very well annotated. So it's a far cry from calling mutations, even calling insertions and deletions or copy number. And this is really work that's underway, and we had a great fortune of working with an immunologist here at the Crick, who specifically works in the field of endogenous retroviruses, and he's been able to come up with some of these new algorithms for the alignment of these sequences so that we can be really confident when we say that they associate. So we've looked at this analysis in the context of adapter, and we wanted to know whether we can determine where the expression of endogenous retroviruses is coming from. Because of course, when we do RNA sequencing on bulk tissue, the signal isn't just coming from tumor cells, the signal is coming from all the other cells in the environment as well. And of course, we wanted to know whether there are any changes in this under nivolumab treatment and whether we can use it to predict it. So I won't go into too much detail here, but we extracted these previous signatures and we've used different types of alignments to see if we can get a consensus on this. And again, I don't want to go into technical detail, but the conclusion of this work so far is that these previous endogenous retrovirus signatures are somewhat poorly annotated with respect to potential overlaps with the other elements in the non-coding genome. So therefore, we did this de novo assembly, and we weren't able to identify any of these previously described signatures in adapter samples, and we didn't see that their expression was affected by nivolumab. But this is probably the most important bit of data to share with you. So we were able to use publicly available data sets of purified immune cells to see what ERVs they express. And in fact, what we found is that many of these newly identified ERV signatures that have been reported to associate with response to PD-1 in kidney cancer are actually highly expressed by immune cells. It's actually the immune cells that are driving their expression. And therefore, this would then appear to simply be a surrogate for high levels of immune infiltration, which we already know is associated with response, is a predictor of response. Now, what does all this mean? Well, actually, it doesn't disapprove that ERVs are immunogenic, and it's still possible that T cells respond to presented ERV epitopes, but it does mean that these signatures are not, they're not necessarily reflecting what's actually happening. And ultimately, I think this is going to require functional investigation where we confirm which peptides drive immune response. And of course, it won't escape your attention that actually there's a CAR-T trial at NIH, which is using this particular kidney cancer specific, so this very specific transcript that's TCR transduced in patients but this is HLA restricted to specific subtypes. There's a lot of caveats about kind of the disconnect between these data. So I think I'll stop there because I've talked way too long. I hope I've shown you from this that metastatic kidney cancer repertoires do contain expanded TCR sequences, that when we treat patients with PD-1 therapy, these expanded clones and retained clones on treatment associate with clinical response. The source of antigen in RCC remains cryptic, certainly in our hands. I'm sure there's lots of work going on elsewhere. And we show that previously nominated ERVs are expressed by immune cells rather than being kidney cancer specific. And I'll just finish there by thanking everyone who's been involved in this group. And thank you for your attention. I'll stop sharing my screen.
Thank you, Samra. So thank you for walking us through these different works you're conducting in your lab in collaboration. So this morning, we actually had one question from Yves, which is, do you believe that biomarker developed in the PD-1 single agent setting, such as the one you've shown us, will be applicable to Nivo-EP, so combination of IO or IO plus TKI? Because the bottom line for us in first line will be to define between these two strategies.
Yeah, of course. So obviously, single agent Nivo in the first line, is redundant. In the second line, it could become redundant in due course. So I think these insights are more about biology, really, rather than about biomarker. And what we're trying to build on now is to see whether in a way, it's more important to understand the non-responders because the signal from non-responders might tell us something about whether they would have been rescued by addition of CTLA-4. And I think the hypothesis is if there is a high number of regulatory T cells, for example, and you believe that CTLA-4 monoclonal antibody depletes regulatory T cells, then those are the patients that would require addition of CTLA-4 for rescue. And then, on the other hand, is there an angiogenesis signal in these patients where you could then feasibly argue that what they need is a combination with a VEGF TKI. So I think this is about a biological exploration that then by understanding non-responder group begins to offer some rationale for combination therapies.
Thank you. So while we receive different questions in the chat, I'll keep asking some questions to you.
Yeah. And Laurence, obviously, I'm happy to switch the discussion to what should have been the topic, if that's of greater interest as well. Yeah.
Well, then the straight question for you, straightforward, will be: you see a first-line patient, never pretreated. How do you decide between IO TKI? What is your strategy?
Okay, so I mean, obviously, we've got the IDMC risk scores to drive this in terms of the clinical markers. We don't have any biomarkers in our hands to help us with this. So for my intermediate and high risk patients, I would always choose Ipi-Nivo at present. So we obviously have mature data from these studies, and I think extrapolating from what we've seen in studies of single agent PD-1 in lung cancer and in melanoma, there's clear evidence that long-term responses may require addition of CTLA-4. CTLA-4 and PD-1 have got a different impact on the CD8 T cell populations, and therefore I think that there's going to be both synergy and additive effect from those. While I think that potentiation of the immune response by the addition of VEGF TKI is still a fairly speculative area, at least in terms of the biological understanding. So although the response rates are impressive, I think it would be important to understand with longer follow-up as to whether what we're simply seeing is addition of progression-free survival benefit that we get with either therapy alone, or whether durable responses will be seen.
So you did not mention PDL1, but that could be the easiest way to try to enrich for response for Nivo-EP. Is that something you use in practice or not at all?
We don't actually. I mean, I know that the funding landscape, reimbursement landscape is slightly different in France. So we've been fortunate to have had access to Epi-Nivo for some time now. In anyone who can make the intermediate or high risk group, and most of our patients can make +1, I think. We've not had to resort to that at the moment. What's approved in UK is axiavelimab, as you know, and I think there are some reservations about that combination, and I'm not sure that the uptake has been as much as had been anticipated, and perhaps that's because of the availability of Epi-Nivo. If we didn't have any constraints at all, I think my ideal biomarker would probably be a transcriptional signature. You know, I really like the work from David McDermott and Tom Pauls, and then subsequently from the 214 study as well. I think there is this very clear demarcation of tumors that continue to rely quite heavily on angiogenic pathways. And I think one of the so I think that could be a useful marker if we can measure it robustly. But I think one of the open questions, and maybe again sort of coming back to my cancer evolution roots, you know, at what point do tumors switch? Because we know that a loss of VHL and upregulation of angiogenesis is a canonical founder event in kidney cancer. So at what point and for what reason do they switch away from that? I think, again, from a biological standpoint, having an insight into that.
So I have several questions that are coming into the chat that may some of them address this point. So one from Eva Laurie, which is, do we know if there's any link between the Alexandrov mutational signature in clear cell RCC and the type of mutations that are involved in the neoantigen generation?
What an interesting question, Eve. So the predominant mutational signature in kidney cancer is the so-called signature 5. I mean, we don't need to worry about what signature 5 is, but it tracks with age. So basically, these are mostly mutations that are accumulated even prior to malignant transformation. So the older you are, the greater the mutational burden, and it's driven by that process. The other mutational signatures are not that well represented, but you know, I'm not sure that we've ever specifically looked at the ones that contribute neoantigens, and we certainly should.
Okay, so another question from Virginie. Do you see any interest in practice to perform systematically PBRM1 and BAP1 staining, but we can also discuss sequencing in clear cell RCC?
Yes, yeah. So, I mean, if I sort of go back to our previous work on kind of mapping when and how these mutations happen and how they impact the clinical phenotype, I think it's extremely compelling. But, you know, I have to be transparent and say that we've not translated this into practice. This, you know, step is actually very hard to perform. One of the reasons being that you know, not all these mutations can be reliably assayed on a single biopsy or a single sample. And I think if you're doing molecular profiling, you would be hard pushed to ask your molecular profiling lab to do multiple samples. But we are now doing some work on a novel method of tumor homogenization to create a sample that's representative of the tumor as a whole. So watch this space. I think IHC is, you know, given that pathologists already assay multiple samples across the tumor. And in fact, every time we talk about intratumor heterogeneity, my pathology colleagues say, listen, we've been doing this forever. You know, you haven't invented anything here. You know, we always look at multiple areas of the tumor. And I think if IHC could be adopted into routine practice and reliably detected these mutations, then I think that could be one way to be confident about them. In terms of the pathways that PBRM1 and BAP1 impact, it's quite clear that PBRM1 drives a much more angiogenic signal. And actually, there are functional data that show that on the back of VHL1, on the back of VHL loss, PBRM1 cooperates with loss of VHL to drive a stronger VEGF signaling still. With BAP1, we know that, again, from preclinical and clinical data, there is more of an inflammatory signature. And then hopefully these are, potentially these are the tumors that might be more likely to respond to IO. Again, all of this requires evaluation systematically in studies, and the beautiful efforts like Bionic in France will hopefully contribute to that, as well as the other studies that are ongoing.
So we have two quick questions for you before we wrap up. The first one is, Bionic did not address the question of TKI plus IO, and Antoine Thierry-Villemain just stressed the fact that we will have maybe access to different TKI IO doublets. And so do you believe that there is one biomarker that could actually help us to choose between these?
It's hard enough already, I think, even to think about like the classes of drugs. I mean, clearly, Cabo does have additional mechanisms of action, but I'm not sure that we have enough data, even in single agent Cabo, to say that this is what's driving the response, or this is what's overcoming the resistance. Again, I just will, and I know it's hard work, but I think preclinical work in this, as well as very careful and considered analysis of biomarkers in all these studies, and really embedding biological endpoints, saying I'm not going to do this study unless I get this biological insight, is what we kind of need to agree internationally to do.
Okay, and so one last before Karim can do the wrap up. Gwenaëlle suggests to ask you this following question. You mentioned Nivo-EP in all intermediate and poor risk patients. Is that your strategy even if you want to achieve a rapid response, or if you have a patient that has sarcomatoid features, is that changing your strategy? Yeah, so patients with sarcomatoid features definitely it's clear evidence that they respond well to combination IO-IO. In patients with rapidly progressing disease, I mean, again, perhaps I'm a little bit biased by years of melanoma practice in IO-IO, but I don't think it's impossible to achieve a rapid response with an IO-IO combination. So at the moment, it's not a consideration in our practice, certainly. Thank you very much, Samra. So I just want to congratulate you again on behalf of the entire group for everything you're doing in the field of RCC. Thank you for taking the time for your lecture. And I'll hand over now to Karim. Thank you very much, Samra. Thank you very much.
Thank you, Samra. And thank you to all speakers and moderators of this excellent session. Really, that I really enjoyed it. Let me switch back to the French now. Donc, je crois qu'on arrive à la fin de ces journées. Et je voudrais évidemment vous remercier. Je vais commencer par nos sponsors. Je vais les citer si vous voulez bien. Je crois qu'on avait 3 golden sponsors qui étaient B.B.S, MSD et AstraZeneca. Donc, un très grand merci. Et puis également Janssen, AAA, Ipsen, Amgen, Astellas, Pfizer. Merci beaucoup. Évidemment, votre soutien a été précieux pour organiser ces journées. Je suis désolé qu'elles se soient faites finalement en virtuel. On a vraiment, je vous l'ai dit ce matin, espéré jusqu'au bout pouvoir se voir au moins partiellement. On fera mieux la prochaine fois. Et s'il y a besoin qu'on échange, on peut le faire de manière informelle, bien sûr. Je voudrais vraiment adresser un grand merci aux orateurs, aux modérateurs pour la qualité des sessions. Les orateurs ont vraiment fait un excellent travail, un très grand effort pédagogique pour rendre plus simple des données compliquées. Et en tout cas, à titre personnel, j'ai pris beaucoup de plaisir à vous écouter tous et toutes au cours de la journée. Je pense que si on se replace il y a 10 ans, je pense qu'on aurait rêvé d'avoir des sessions de cancérologie généto-urinaire d'une telle qualité. Je ne suis pas sûr qu'on l'aurait imaginé, pour tout vous dire. Un grand merci au comité d'organisation qui s'est arraché les cheveux depuis 1 an avec cette fichue pandémie pour trouver des solutions, pour modifier les choses, etc. Et toujours dans un super esprit. Et c'était très chouette. Vraiment un grand merci à eux. Un grand merci à vous tous pour votre participation aujourd'hui. Et puis, je voudrais bien sûr adresser un merci spécial à Swazik et à Adélaïde qui se sont occupés de faire en sorte que tout ça fonctionne bien et soit bien mis en musique. Au passage, les présentations que vous avez entendues aujourd'hui, je suis presque sûr, seront disponibles en différé très vite, peut-être dès ce soir, sur le site d'Unicancer. Donc, n'hésitez pas, si vous avez dû vous absenter pour une raison ou pour une autre, vous pouvez y retourner et écouter vos orateurs favoris. Et puis, avec tout ça, je vous dis, écoutez, à l'an prochain, j'espère en présentiel, on sera tous vaccinés, le virus sera à peu près sous contrôle et ça sera très bien et on pourra profiter sûrement d'une belle journée printanière parce qu'on décalera au printemps ou à l'été et savourer des moments tous ensemble. Merci beaucoup à tous et très bonne soirée et à bientôt.